Hello. I can't quite hear you. Can you hear me? I can't hear you. Let's see.
Ah, there it goes. I got it.
Oh, I was like, uh-oh. Not a good start.
I'm going to stop the speaker test. Okay, good.
Okay.
Cool.
Cool.
Great.
Yeah, so I guess I'll just introduce you at the beginning, and
Okay.
if you want to bring up your slides now, that's totally fine. And
Sure.
then, yeah, like I said yesterday, I'll monitor the chat along with Tessa. She's just going to get on pretty soon now here.
Okay.
And I will probably stop my video for your presentation, and then I'll jump back on afterwards. So
Sounds good.
awesome.
Okay, so I just tried sharing the screen there. Does that work?
Yep, I can see it.
Okay.
Looks like we got a couple people on already too. So
Perfect. Does this part show up? Should I move that?
I don't see. I see the bottom part of your computer, but
Oh, okay. You don't see like the ID mute stop video thing?
nope.
Okay. There.
There you go. Yep.
Cool. How's the morning?
Not too bad around here. Just a
Yeah.
couple meetings. So
you're in Iowa City, you said?
Yep.
Which I'm not as familiar with Iowa City, but are you in a separate building? Are you affiliated with another hospital setting or something?
So we are at the Consortium. We're a 501c3 nonprofit, but we're housed at the University of Iowa. So we're kind of funky, and then we are funded by state grants or state dollars and CDC dollars. So that comes through the Iowa Department of Public Health.
I see.
Yeah.
I missed the first part. For some reason, my video froze. Where did you say you're located?
Sorry, we're at the Research Park in Coralville, but the what am I trying to say? The university houses us, so we're out of the cancer center, technically.
Very cool.
Yep.
In terms of timing,
yep.
What's the general goal again?
We have an hour. So however you want to use that time is totally fine. We can, if you have time after and there's still questions, we can always stay on. I have going on after, so.
Okay. I think it'll go around 40 minutes or so.
Okay, perfect.
So that should give some time for questions.
Perfect.
Hi.
Hello.
Hi, Jared. How are you doing?
Good. How are you?
Good. Sorry, I'm just getting my camera fell off as soon as I got it adjusted here.
No, not a problem.
There we go. I think that's good. Nice to virtually meet you.
Yeah, you as well. I think I've learned the ins and outs of this Zoom meeting business, but
yeah, we've really liked it so far. I've definitely made my own. When I say I've had IT issues, I'm like, it's me issues. I've messed things up before, but yeah, once you get going on it, it's actually pretty easy to use.
yeah, it seems really pretty intuitive. So
yeah,
maybe I'll have to convince the powers that be at our institution.
yeah. Jared, I can't remember if you had mentioned or not, but are you planning on coming to our spring meeting at Mary Greeley on the 4th, or will you be available?
I think we had talked about that, and given that I'm at Mary Greeley one day a week, it would be super convenient. I don't remember if we followed up. Let me see if I have it in my calendar here. It's April 4th?
Yep.
Oh, okay.
Or I'm sorry, April 20th. April 20th will be a name. Sorry, I don't know why I said the 4th.
No, that's all right.
All right, well, it is noon.
Okay.
So I don't want to keep anyone waiting or anything. So I just wanted to introduce you, Dr. Tucker, to everyone who's on. I'll read your bio and then I'll let you take it over from there. So Dr. Jarrett Tucker is a native Iowan and graduate of Iowa State University's doctoral program in counseling psychology. He completed his pre-doctoral internship at Cambridge Health Alliance, Harvard Medical School, and postdoctoral work at Des Moines University and the Polk County Juvenile Courts. He is currently an assistant professor at Des Moines University and the first clinical psychologist at Mary Greeley Medical Center, William R. Bliss Cancer Resource Center. A generalist by training, he seeks to apply the long tradition of behavioral health care to the specific needs of cancer patients and their families. So thanks everyone for joining, and thank you, Dr. Tucker. Go ahead and take over.
Great, thanks, Lindsay. Can you hear me okay? Okay, and the video is coming through all right, so no problems. Great, so yeah, I appreciate the introduction. I think my real goal for this presentation is to take what I've learned sort of as a beginning psycho-oncologist here to give a little bit more information about the role of mental health care, some of the real disparities that exist in recognizing and treating mental illness in cancer patients, and it exists across all health conditions. It's not unique to cancer, but understanding some of the specifics that relate to that, and then really trying to talk about how do we address that based on some of the guidelines from the National Comprehensive Cancer Network as well as the COC. So, in a nutshell, my hope is that you'll be able to kind of recognize some common behavioral, psychological, and psychiatric concerns related to cancer care. This is all the way from screening to incidence rates to treatment and care, and understanding the psychosocial disparities that exist in terms of risk and all of those various elements. And then finally, we're going to try and identify some really easy ways to try and address those existing disparities through some reference to the guidelines that are already available. I do hope that you'll interrupt me if there are questions. I know that there's a chat box available for folks that might have questions or concerns. So please be using that, and I'll rely on Lindsay there to help navigate as things come up. Great. So to begin, we're aware that all the way from the World Health Organization, very early director in the 1960s, Dr. Brock Chisholm, really talked a lot about the role of mental health care and the idea that without mental health, there can be no real physical health, especially in cancer patients where we're talking about end of quality of life, and especially as we're talking about maybe not being able to necessarily prolong survival through mental health treatment, but definitely being able to improve quality of life. Just the real importance of talking about mental health issues. And that's especially motivated by just the commonness and the realities of mental illness in cancer care. So I think what I've learned a lot while working with patients with cancer is just the real high prevalence of reactive grief, pain, and fatigue. It's absolutely essential not to treat those conditions as, or over-pathologize those conditions and think about them as sort of a part of cancer diagnosis. You know, we know that somewhere between 60 and 90% of cancer patients experience fatigue. Fatigue is often the most distressing aspect of care in terms of quality of life. And we also know that fatigue is a hallmark of depression. It can lead to really strong emotional reactions when you're feeling really overwhelmed, when you're feeling like you have very little energy. So it's important to not maybe over-pathologize fatigue, for example, as a component of depression. But that being said, there's still a very high percentage of unrecognized psychosocial needs and disorders at all stages of the cancer trajectory. So we know, for example, adjustment disorders are about 40 times as prevalent in cancer patients. You know, and adjustment disorders are basically reactions to stressors that are sort of outside of the normal range of stress reaction. We know that post-traumatic stress disorders are about twice as prevalent. Depressive disorders are 3 times as prevalent, and the percentages there are on the slides. And suicide risk is about twofold increase, and the greatest risk is within the first year. Especially when those psychosocial conditions go untreated, there's really negative consequences for cancer patients. That's in terms not only of quality of life, but also in terms of length of life. You might already be aware, but just having a mental health concern leads to about a 10-year reduction in average life expectancy, which is pretty surprising or pretty difficult for folks who work with mental illness to see and understand that just by virtue of having a mental health concern, you're likely overall you're going to experience a decrease in length of life. And the biggest areas are in the areas of psychosis and bipolar disorders, and we'll talk a little bit about why that might be. It's really important here to know that it's not because of, oops, I might have skipped some slides here. It happens not because of the specifics of having a mental health concern. So it's not as a result of suicide or sort of these unnatural causes. Most of it has to do with a result of extended chronic or acute illnesses. So 67% is due to acute and chronic illnesses, whereas only about 17.5% is due to suicide and injury. So basically, it's this increased risk of mortality is because of untreated comorbid conditions. It's also a result of the sort of comorbidity of mental health concerns with lower socioeconomic status and a lot of behavioral risk factors and poor access to care. So I think it's really important here as we're thinking about mental illness and cancer incidence. So we'll break this down just a little bit further. It's mental illness isn't a cause of cancer. It doesn't necessarily even independently exacerbate cancer. For example, we for a long time thought that being depressed or having stress might act sort of on the hypothalamic pituitary adrenal axis, the HPA axis, lead to immune suppression, possibly promote faulty DNA repair. But really, there's not a lot of evidence. So across the past 50 years of studies, there's very little evidence that mental illness is a cause of cancer or exacerbates cancer. So we can kind of reassure our patients that they're not going to give themselves cancer through stress, personality, or illness. But there is a link between depression, distress, these other things, and other factors that kind of cause or exacerbate somebody's cancer treatment and healthcare. There's a real high comorbidity of mental health and substance use disorders. And we know about 30% of incidence of cancer is attributable to smoking alone. On the right there is the rates of smoking by a mental health concern. So for folks who are have no mental illness, the rates are around 20%, a little lower now, around 15%, even down to 11% in the US. But for folks with major depression, alcohol use, PTSD, or bipolar, the rates kind of go up dramatically. And especially when I'm talking to students about treating folks with bipolar illness, it's almost safer to assume that the person is a smoker, has substance use concerns, just based on the high prevalence rates, right? There's a real high correlation of adverse childhood events and obesity, which is, again, another sort of independent risk factor for the development of cancer. So adverse childhood events are things like being physically hurt by adults, neglected, exposed to substances. All of those things lead to increased risk for obesity. Folks who have greater than 4 adverse childhood events, as opposed to those with 3, have around about 30% rates of obesity, compared to about a lower percentage, about 20% for those less than that. So, and we know, again, obesity, diet, exercise are all going to account for, around 40% of incidence rates of the development of cancer. And finally, lower rates of screening and adherence for those who have a mental health concern. So there's been some good evidence to suggest that folks who are depressed tend to have lower adherence rates, about 3 times higher rates of non-adherence to their recommended treatment than folks who are not depressed. And we'll take a little deeper look here at why that might be the case. But basically, this is all saying that the incidence, screening, and treatment is really affected by mental health concerns. It's not necessarily a result that mental illness is a risk factor for developing cancer, but it can affect some of these other concerns, sort of indirectly here. The final piece, or way that depression or other mental health concerns can really impact cancer treatment, is through kind of its way of affecting cognitions around and beliefs about cancer and its treatment. So, for example, one really useful model that's been developed is the cognitive social health information processing model. So basically, it's a way of saying that there are many factors that might influence somebody's decision to be screened for breast cancer, for example, or to adhere to chemotherapy treatments or others. At the first level, there is sort of these health-relevant encodings. So these are just the strategies that somebody uses to understand themselves and the situations that they find themselves in regards to health. So, for example, some patients might see health threats everywhere and scan for them. They might be always attending to their own bodily cues and highly aware of any differences. They might be very attentive to any changes, whereas others really might not attend to much information about their own health risk. They really might just actually try and actively avoid it. They might sort of blunt information. There's at the level of beliefs and expectancies. So those are sort of the expectations about self-efficacy and outcomes related to their treatment. So, for example, someone might have a really high perceived likelihood of developing lung cancer from smoking, but maybe others don't see that link, they don't believe in it. Someone might have really low self-efficacy about being able to give up tobacco. They might really not believe that treatment is going to be effective. So those sorts of beliefs and expectancies regarding treatment. And kind of next is sort of these goals and values. And those are just sort of the desired outcomes that a person might have. It's critical to be cancer-free, or personal motivations like being healthy enough to take their dog on hikes, or whatever else kind of specific to that individual motivates them. And the next level is emotions or affect, and those are just sort of the positive and negative things that a person feels that might continue to contribute to their treatments or their decision making. It includes hopefulness or negative feelings about the self. It includes irritability. And we focus a lot of this as psychologists in terms of highlighting those emotions and addressing those emotions that might be interfering with treatment. And then finally is these sort of self-regulatory competencies. So those are the skills for dealing with barriers that somebody might have in their cancer care. It might be use of self-rewards to motivate themselves for doing things, or it might be having good distress tolerance skills to deal with delayed gratification in going through treatments. All those sorts of things go into somebody's adherence to treatment, their screening of treatment. And all of these things sort of relate to the patient behaviors outside of the clinic when we're not meeting with them in person. And we know that together, adherence really does impact treatment outcomes. You know, the differences between those who adhere to treatment and those who don't, you know, there's about a 26% improvement in outcomes. So adherence isn't the only part of recovery, but obviously it's a big part. And as psychologists, we really try and address all of these things. So, you know, we've sort of so far reviewed that mental illness is much more common in cancer patients than the general population, tends to go unaddressed. It's not necessarily an independent risk factor for cancer incidence, but it does predict substance use, diet, exercise, screening, adherence, all of these things that lead to lower life expectancy, lower quality of life. But it's maybe not apparent why we have to have a mental health professional or someone like a psychologist involved in routine care. You know, I know that obviously we're doing a lot of these sorts of things already. We're incorporating the biopsychosocial model. We're trying to develop good rapport with our patients. We have expectations for patient-centered care that we're already providing. You know, the COC has recommendations around collaborative care models, all those sorts of things. But there are a few reasons why having a mental health provider is important in sort of addressing these disparities. Why a mental health provider kind of is a unique addition in some ways. And that's sort of my role here. I've started here at Mary Greeley as a psycho-oncologist. I've been there since January of this year, so only a few months at this point. But I can tell you a little bit about my work and what we've already sort of started to do and what I've seen. So to begin with, when we tend to approach behavior change, you know, again, diet, exercise, smoking, huge contributors to incidence of cancer and adherence and treatment. When we try to address those things, usually in routine care, we might not be able to really integrate fully the behavior change into the person's life. So for example, they've done really intensive study around trying to increase somebody's exercise routine, to really decrease their caloric intake, to do all sorts of things to address some of the risk of cancer development. You know, in one example, they had a randomized controlled trial of really intensive treatment where folks were sort of restricting themselves to a 1,600 calorie diet. They had weekly cognitive treatments. They had 4 trips to the gym every week. You know, they were being documented. And ultimately, these patients lost about 10% of their weight over 6 months. But by about 3 years, or by 1 year, they'd regained about a third of it. And by 5 years, they'd returned almost 100% of the sample had returned to baseline. And in addition, really a hyper focus on diet and exercise can kind of increase preoccupation with weight, preoccupation with food, eating disorders. You know, orthorexia is like this really intense focus on the body and diet. And those things can actually increase as a result of intense sort of rigid patterns of behavior. The other thing is that exercise routines or regimens don't really say a whole lot about the rest of the day. And sedentary behavior, so let's say you work out for 30 minutes once every 4 to 5 times, 3 to 5 times a week. That doesn't really say much about the other 23 and a half hours of your day. And sedentary behaviors, along with exercise, are an independent risk factor for cancer incidence. So it's important, instead of focusing really on increasing strictness around exercise and diet, what a mental health professional can do is really focus on integrating these changes slowly into the patient's lives. So instead, we focus a lot more on encouraging body acceptance as opposed to weight loss, which is sort of intuitively, or sort of not counterintuitively, actually increases a person's ability to regulate activity and these sorts of things. Focus on active embodiment. So we're really, instead of encouraging structured exercise, we're really trying to integrate activities into one's daily schedule through occupational, household, recreational movement, all those sorts of things. And also we're really just supporting reliance on internal regulation. So helping the patient to become aware of their own internal cues around hunger and satiety, as opposed to really encouraging dietary restrictions. So all of those things can help improve changes in behavior over time. And that just takes time. It's not something that can happen right away. We really have to understand our patients and their unique motivations. Mental health treatment, just to give you a general overview, and this is motivated just by a sense of helping to talk to our patients about why mental health treatment is indicated, as well as just to be able to describe it in sort of a convincing terms for our patients. Mental health treatment is a little different, where it has sort of these general change mechanisms. You know, it's not something that lends itself easily to randomized controlled trials where you have sort of these active ingredients that lead to change. Instead, it has these much more general change mechanisms. So I won't really get into too much depth here, but they rely primarily on problem activation. So the patient has to come into contact with the origins of their concerns. So for those patients who maybe are, like we were talking about earlier, avoiding or blunting their health risk, or not, we're wanting to avoid their concerns, we're really trying to bring exposure, bring contact, to really identify those problems and address them. And then resource activation is sort of the secondary piece, where it really relies on a good relationship with a counselor, a mental health provider, to help that patient negotiate their priorities, increase their motivation, and develop sort of a contract around what they're going to do, what are the goals of treatment, and then increase hopefulness. So those two things together really form the therapeutic relationship. A working alliance with patients in mental health treatment is basically based on, we're not avoiding your problems. We're talking about the tough stuff. We're talking about, your difficulties with smoking that you're trying to hide, or we're talking about your sexual concerns. We're talking about the stuff that you wouldn't normally talk about, and we are instilling hope, and we're actively working together in a way that makes sense. And we know that mental health treatment is really effective in terms of comparison to other treatments. So one way of measuring treatment efficacy is something called numbers needed to treat. So numbers needed to treat is just the number of persons you need to give a treatment to in order for there to be some benefit to that group compared to the population of people who aren't receiving treatment. So with psychotherapy, and this is across all mental health conditions, so mood disorders, stress-related disorders, psychosis, bipolar disorders, all these conditions, generally psychotherapy is really effective. You only need about 3 people to receive psychotherapy before you really see a benefit to that group as compared to those who aren't receiving treatment. That might seem like a high number until we start to think about some of the other really well-accepted treatments. So for example, compression stockings after surgery, you need about 7 persons to receive that treatment for anyone to see benefit. Antibiotics for sinusitis is about 19 people. Statins for heart attack and stroke prevention is about 120 to 125. And aspirin as well is about 129. So all of this is just to say that psychotherapy is effective, and as effective as some of our most effective medical treatments. It's interesting actually that for prophylactic aspirin, the clinical trial where they were examining its use was actually stopped because they felt like it was unethical to withhold treatment from the group who wasn't receiving it. So if we think about that same standard and we apply it to mental health treatment, that would be a nice idea if we could think about that it would be unethical to withhold psychotherapy. And that's also true for substance use it has moderate efficacy for substance use concerns. It's probably most effective actually for smoking, and that includes cannabis. And it's maybe least effective for opioids and polysubstance abuse, where folks are using multiple substances. But overall, mental health treatment is effective. There are limits with mental health treatment, just like any other treatment. I think the biggest surprise to researchers has been that treating folks with mental health concerns doesn't ultimately prolong life for the average patient. There was actually some early hope that therapy would directly extend survival. So Irvin Yalom was an early group researcher doing some research on cancer patients in the 80s and 90s. And they actually found, interestingly, that survival was prolonged by about 18 months in their initial study. But since that time, we've really found out that there was some problems in that study. There might have been some sampling bias, some other things. And it doesn't really seem that psychotherapy directly prolongs life. But it does address behavioral mechanisms. And to the extent that psychotherapy can address those underlying behavioral concerns, as we've talked about, adherence, smoking, diet, exercise, it can be effective in improving life expectancy. So for example, really well-managed depression in elderly led to about a 45% reduction in death rate at about 5 years. And this was in the Prospect study in 2004, which is the Prevention of Suicide in Primary Care Elderly trial. And basically, they found that actually the reduction in death rates and early mortality was largely due to death by cancer rates. So the managing depression seemed to really impact ultimate life expectancy by improving various behavioral mechanisms. And psychotherapy also leads to greater chemotherapy dose adherence, fewer dropouts in treatments, and other things that do lead to longer life expectancy. And also, just sort of more broadly, mental health treatment improves folks' quality of life, leads to decreased anxiety, depression, improved social support, improved well-being. And I think we kind of ask ourselves, sort of as Anne Fadiman did in her 1997 book about the spirit catching you and you fall down. Really, we have to ask ourselves, which is more important here at the end of life? Is it the life or is it the soul? And how important do we really want to, how can we overestimate the importance of quality of life here? So we'll have plenty of time for questions, I think, at the end. So I'll just kind of go quickly here through what the COC might recommend in terms of screening for mental health concerns based on those psychosocial disparities that exist. And we'll talk a little bit about what the Commission on Cancer recommends for these things. So some of this might be a review, but if not, it can be some good new information, and even if so, it can be a helpful reminder. So in about 1997, the National Comprehensive Cancer Network had a multidisciplinary panel to try and address psychosocial elements of cancer treatment. They found actually that the #1 reason the psychosocial domain wasn't better integrated into cancer care was maybe not necessarily a lack of providers or a lack of need, but rather that actually oncologists really didn't want to suggest that their patient might have a mental illness. And it's not necessarily their fault. Patients and physicians aren't immune to the stigma that exists around mental illness. But it was a big barrier is difficulty talking about this concern or the possibility that somebody might be depressed and getting them proper treatment. So in around, kind of as a result of that panel and moving into 2004, the NCCN began to decide that maybe distress was a good way to try and address this. So distress is maybe a more acceptable term for us to use to talk about mental health concerns. It doesn't maybe carry the same level of stigma. To be stressed isn't quite so bad as to be depressed and these other things. And as a psychologist, it's maybe not the most accurate descriptor of mental health concerns. It sort of confounds anxiety, mood, stress-related disorders, all those sorts of other things. But it has really good clinical utility to use the term distress, especially for screening. So in 2004, actually, the NCCN named distress as the 6th vital sign, along with blood pressure, temperature, pulse, respiratory rates, and pain. And the reason is that the distress screening, using distress, would really allow physicians to focus on curing patients and their primary role as oncologists, but still being committed to biopsychosocial treatment and referring patients for ongoing care. And just a way of conceptualizing distress, you know, this is sort of the Yerkes-Dodson stress curve here at the right. Levels of stress are actually useful. There is something called eustress, where we're sort of being more activated, and there's performance does increase. You know, when I talk to college students, I talk about when you're thinking about yourself in the middle of summer, you're not having much stress at all. You're likely not even motivated to even do the dishes. You know, when there's very little stress in your life, you're probably not going to perform particularly highly. So there's a level of stress that is healthy and useful. But then there's a level of stress that is no longer useful to the person, and that is distress that leads to exhaustion and breakdown. So it's kind of a way of, distress is sort of a way of monitoring our patients to see where they're at in that stress performance curve. And the NCCN has some guidelines about when is distress maybe too much, and I tend to agree with those. And all of these efforts that the NCCN has done, I think, have been very effective. They found that compared to non-NCCN institutions, there's a difference of about 20% in those who screen for distress. So having some guidelines here, having some recommendations around distress screening seems to increase compliance with these things, unsurprisingly. So when we're doing distress screening, there's a few things just to be aware of. So if you're thinking about integrating some distress screening measure into your treatment or your care, basically, so again, here on this left-hand graph, we see just the high prevalence rates of depression, distress, and anxiety in cancer patients. So levels of distress are somewhere around 42.5%. It's that number in orange there. Levels of depression, about 27%. Levels of anxiety, about 33%. So we just see the high base rates. The problem with any sort of screening or test, and you're probably aware, is that there's always going to be false positives, where you're saying somebody is distressed when they actually aren't, or false negatives, when you're saying somebody isn't distressed when they actually are. And brief screeners are generally very good at not saying someone isn't distressed when they are. So ultra short screeners, like the one that the NCCN recommends, are really good at excluding possible diagnoses. However, they're not necessarily very good at confirming a diagnosis. So in your treatment center, you should really consider how available services are and the cost associated with a false positive. So we see, again, the rates of false positives in depression, saying that somebody's depressed when they might not be, using a distress screener is about 66%, right? So 66% of folks who are screened positively using this distress screener are maybe mislabeled as being depressed. So if there's a very low cost of a false positive in your patient population, then short screeners are really maybe a good way to go. You know, if there's not much cost associated with getting somebody referred to treatment, if the services aren't already kind of over inundated, there's availability of a provider, then definitely you probably don't mind erring on the side of a very brief screener. And so where I'm currently at Mary Greeley is I do a lot of sort of this triage work. So it's pretty low stake where we're working at, that somebody gets referred to see me and they don't actually have a mental health concern. So, you know, meeting with me isn't super painful for our patients, hopefully. Even if they're not necessarily in need of ongoing treatment, they get a chance just to talk about their concerns briefly, and we meet. And then my job is really to do a lot of triage around what level of care this person might need. So I kind of work with them to determine a diagnosis, if there is one. Based on that diagnosis, I sort of disposition them a number of sessions. We might meet for as few as 4 sessions for things that are a little bit less overall distressing, things that are not interfering with their lives as much. 2 is on the high end. I might see somebody for 8 to 12 sessions for more significant concerns where there's maybe a history of trauma, or there might be some underlying personality factors. And then also my job is to refer persons on to other treatment providers in the community or to help make some decisions around that. So we do use the ultra short screener that's recommended by the COC and rather the NCCN. It's consistent with the COC recommendations. So what does the COC stay around distress screening? So they stated in standard 3.2 that by 2015, all cancer centers should have a program to identify distress and triage to resources. It should be a minimum of 1 time during a pivotal medical visit, which can include a post-surgical visit, chemotherapy discussion with the medical oncologist, a routine visit with the radiation oncologist, post-chemotherapy follow-up, etc. And then the cancer committee should select a screening tool, and folks should undergo training for that tool. If there's evidence of moderate or severe distress using the tool, a member of the patient's oncology team, like the psychologist, or it could be anyone within the oncology treatment team, should assess their psychological, behavioral, financial, and social problems, which would initiate the distress and related needs. So it's basically just a way of saying, okay, we've screened, what do we do when that person screens positive for distress? So all these things, according to COC guidelines, should be documented in the medical record when the screening is positive, who was referred to, and what follow-up was done. And a psychosocial services coordinator is required to oversee that activity and report that to the cancer committee annually. So we're still sort of working on integrating this at Mary Greeley, where we're trying to track these numbers, and that's a part of what my job is to track referrals and the decisions that were made and report that back. And the person who's the psychosocial services coordinator can really be anyone from the social worker, clinical psychologist, or other mental health professional. And so that's sort of up to the individual center to determine what kind of level of licensed professional they want to have. And then here's just sort of the summary that should be reported back at the end of the year in terms of patients screened, referred, and where they were referred to. So I'll give you just the NCCN's sort of distress thermometer. You might already be familiar with it, so I won't go into too much depth. But basically, the way that they use here, and this is what the base rates were that I showed earlier, where we're having a number of false positives, not too many false negatives, but an acceptable, I would say, an acceptable amount of accuracy. So the distress thermometer is a good tool, I would say. So the distress thermometer, anything of 4 or greater triggers further assessment. And that doesn't mean that they're getting referred to a psychologist right away. That just means that you're going to discuss a little bit further to assess. So it's a score of 4 kind of initiates that discussion. And then there's also some check boxes that the patients use to cite practical, emotional, family, and physical concerns that they might be having. So one way you can introduce the distress thermometer, and again, it's available freely by the NCCN, is just to say, one thing we know about cancer treatment is that it can be really stressful for many folks. So we're normalizing the need for mental health concerns in this population, especially given what we've talked about the high prevalence rates. This is absolutely true. And then you can say something like, would you mind filling out this questionnaire that asks about how you're doing overall, any concerns you might have? Once you finish it, we can chat about any concerns and determine how to help. So let's take an example here. Let's say someone, this fictional person, Beth, checks off panic, depression, fatigue, and she scores a 6.5. She fills it out to 6.5 meter. So we've determined, okay, this is somebody who needs to have a brief discussion in the medical encounter at one of those pivotal medical visits. And she's checked off panic, depression, and fatigue. So what we might say is then just sort of say, I noticed you circled a 6 on the scale, which tells me you're feeling pretty distressed. I also noticed that you checked panic, depression, and fatigue. What would you say has been maybe bothering you the most? So this is just an open question to allow the patient to tell you a little bit about their concerns. And then just using some open exploration. If you're familiar with motivational interviewing, really it maps on nicely here to just sort of exploring what's important to the patient, what's distressing them. And you're sort of doing a sort of in-the-moment assessment around their concerns. If you get a sense, and this is sort of where training can be useful around what things to be really looking out for. But if you get a sense, and usually anything above a 4, again, you're going back to that base rate slide, you can kind of think about maybe it's worth just referring everybody who is circling above a 4 or 4 or above. But if you get a sense that this is somebody who would need additional services, you can say, there's a lot of services that we have that help. And then here's where we're at, the Cancer Resource Center in Mary Greeley. Many persons find helping talking to a psychologist can be quite effective. And then asking permission, can we look at some of those options for you today? Any way that you can sort of make this a standard treatment, say this is just standard protocol, this is what we do, this is not anything unusual, there's nothing about you that's bizarre, this is just this is just a standard practice, that the biopsychosocial approach is normal, that it's important to talk about all aspects of health and wellness. And then if you have any sense of what this particular person might get in terms of benefit. So for example, Beth was saying she was feeling really fatigued, really overwhelmed. Maybe you get a sense that that's because she's just not certain about chemotherapy. Maybe she observed her own mother go through chemotherapy and just saw the fatigue that she was going through. So you can really personalize the message around, talking to a psychologist can really just give you additional skills, maybe to, first of all, give yourself permission to not have to be so motivated, to give yourself permission to be easy on yourself at this time. They can also talk about how to plan your daily activities and structure your life in a way that can still be rewarding and help you to prioritize those things. So just some way, it doesn't really matter so much, but just some way of trying to motivate this within the person's life. So I've talked about a lot of things, and I'm very interested in answering any questions folks might have. But the main take-homes here are, behavioral and psychosocial factors are a major element of cancer risks, costs, outcomes. They're really going unaddressed in many ways. There's a big component here of mental health concerns that contribute to outcomes that are still going untreated. Distress screening, like the one we talked about, is a great way of being sort of the thin edge of the wedge of getting folks into further treatment to address their concerns. And to the extent that you're comfortable, you can use the distress screening scale that we talked about and begin that process of assessment and referral in the room with patients. Great. So here are my references for this slide. For this presentation. I'm very happy to answer any questions that might be going on.
Thanks, Jarrett, for sharing all that information. If you have a question for Jarrett, could you please raise your hand and I can allow you to talk, and or if you don't feel comfortable, just feel free to chat it in the chat box and I'm happy to monitor those. So. Any questions? Any of our panelists? I'm going to put our folks on the spot here. Oops. It looks like we have a question from Lindsay Heck. She asks, how do you see the field of psychology changing over the next 10 to 20 years?
That's a really good question. It's hard to say about where, there's been every year I go to professional conferences, we talk about, integrated healthcare and trying to get sort of the long tradition of behavioral health into the clinical setting. I do see psychologists trying more and more to legitimize the profession through using guidelines, like they recently just released treatment guidelines for PTSD that are approved by APA. And there's trying to be, in terms of our licensing exam, they're moving to a competency-based exam that's above and beyond sort of a knowledge-based exam. So there's a lot of efforts to sort of legitimize psychology, which are good in many ways. And also, there isn't much I think we have to do to legitimize ourselves, because like I was talking about earlier, the evidence for psychotherapeutic treatment is there. It's just a matter of folks taking it seriously and are being able to present that information in a way that is convincing to the medical profession as well. So ultimately, I see ourselves moving more integration. I hope that we don't lose our roots or our grounding in that process.
Awesome. Thank you for that answer. Hopefully that answers the question.
Yeah, I don't know if that's what they're hoping, but that's my 2 cents.
She said thank you, so I would assume. Good. We have another question from Kelly. She asks, do you see the reluctance by patients in participating in any form of distress screening?
You know, so far, the nursing staff at our hospital, which is largely responsible for these, don't actually see much reluctance. Some folks, you know, and I think it's appropriate if somebody scores a 1, they don't check anything off. The nurse just sort of says, okay, it seems like at this point that's not something that's, you know, you're really concerned about, and they move along. There is sort of a reluctance. So the distress, I don't see much reluctance in the distress screening. There's maybe a little bit more reluctance to be referred to see a psychologist. A lot of patients say, well, you know, I have cancer. I don't have, you know, I'm not disturbed. I'm not crazy. And I think that that's a legitimate concern because of the stigma of seeking help. People really begin to think there must be really something wrong with me if I needed to see a counselor about these things. So we really try and work, if I can get them into the room and see them, I really try to work to dispel that and talk about just the strength required rather than the weakness of seeking help and the efficacy of treatment. And then it's a little absurd actually to not seek treatment given its efficacy. But yeah, we do definitely see reluctance in our patients, and that's something we have to actively work to address as mental health providers once we've gotten them in the room. Sometimes it requires follow-up for me, you know, several phone calls. I'm pretty persistent. When a patient has been referred to me, I will usually call. You know, I have, you know, my own protocol for that. I call 2 times and then I send a letter. But I try to be pretty persistent.
Awesome. I don't see any other questions. I am happy to wait a couple more minutes. I mean, we're still under time here. So if anyone has any more questions and they either want to ask with their raising their hand or putting it in the Q&A or adding it to the chat box, I'm happy to monitor those.
Yeah. Yeah, and I think, I'll be very curious if there's ways that I can follow up and be helpful. And I would love to be more connected with the Iowa Cancer Consortium here and thinking about ways to be connected and integrated with other members. So hopefully this is the beginning of a longer dialogue.
We do have one more question that popped up. How did you become interested in the field of psycho-oncology, Jarrett?
Yeah, I think, you know, I think like many folks who go into this area, you know, my own personal family history of struggling with cancer, and I think watching my own grandfather go through the process, and just seeing the real stress that it places on families and his own kind of internal process. And to be honest, it's something I wish my grandfather wouldn't have had quite the level of stigma around seeking help that I know is very common amongst this population. Because I think that there was a lot of things that he was going through that he had to end up going through by himself. So I think that was one of my big motivations for pursuing this. And I'll say, just as a random add-on here, is that I think when it's important to not over-identify with our patients, you know, especially if I were to see somebody who was like my grandfather in some way and being reminded of that. It's important to keep healthy distance, but at the same time, to the extent that we can empathize with our patients, I think is oftentimes the extent to which we can help them. So it's not totally unhealthy to have these motivations for getting into the field. We just have to be mindful of it.
Yeah, definitely. Thanks for sharing that.
Sure.
Any other questions? I have to monitor like 3 different screens here.
Yeah, there's a lot going on.
All right, it doesn't look like it. We do have a bit of a survey afterwards. It'll just pop up on everyone's screen. So if you have any, it's just like a short little, how did the presentation go? Did you learn things? Stuff like that. If you guys have any questions for Jared after the fact, I'm happy to field those and send them his way as long as he's okay with that. Also, we will have these slides available, and the presentation is being recorded or was recorded, so we will have that available on our capacity building series site, hopefully within a couple weeks. So thanks everyone for attending, and thank you, Dr. Tucker, again for presenting.
Thanks, Lindsay. Appreciate your time.
Yeah, thank you. I will put the poll up for everyone.
Sounds good.